to the peritoneal cavity. Okay. Any other sign symptom to say that there is basically an increase in portal hypertension? Is there any indications to say that there is portal hypertension in the patient?
Is it abdominal distension?
Okay. Yes, go on, please.
The caput medusa, doctor?
Yes. There are many indications to say that there is actually an increase in portal hypertension. So you can see what are the classical signs. Anyone? Sorry.
Do you mean presenting the stigmata, doctor?
Yeah, I mean, what indicates that there is actually an increase in portal hypertension? What sign symptom shows that she has an increase in portal hypertension? One is you said about caput medusa, right?
Yes, doctor.
Yes.
The patient present with caput medusa.
Yes, there's one. Okay, this basically indicates there's an increase in blood accumulate in the vein, in the portal vein. Yeah, because there is basically the back pressure. The back pressure that result in the vein engorgement. That's why you see a caput medusa. Yeah. How we explain spider navy?
Basically, from spider navy, what I found is because of increased free estrogen in the blood, because estrogen is supposed to be metabolized in the liver, but because of the hepatocyte damage, necrotic of hepatocyte, so high free estrogen, and estrogen will trigger the vasodilation. Thus, this will swollen the blood vessel. Yeah.
So all this actually indicating that there's a liver problem that actually lead to portal hypertension, and one of them because as you say, the estrogen is not being metabolized in the liver, so there's an increase in estrogen level that lead to spider navy. Yeah. And any other things that can say is that the patient have the same problem?
Maybe the spleen enlargement, doctor?
Yes, spleen enlargement, but how can you detect it?
Spleen enlargement we can detect through palpitation, right? From the physical examination.
Yeah, from physical examination, you can actually detect some of the spleen enlargement. How you do it? Any
I
idea?
think from umbilical we palpate to zone to zone. I don't remember. But I think we start from umbilical somewhere.
You can see actually abdominal enlargement basically.
So if we see the abdomen is enlarged, then we can say that the spleen is enlarged. But
it can also be the liver. It can be also be the liver or the spleen. But the liver will be easier to palpate because it's on the right side. Right, Balkis? No, Balkis?
Yes.
Yeah. So,
right.
but do you find that the liver in the patient enlarged?
No, doctor.
No, doctor.
Okay, why is it not enlarged?
I think because of the cirrhosis.
Yes, because of the hepatitis that cause cirrhosis. So there's actually shrinkage of the liver. So the one that causes abdominal enlargement is due to the spleen enlargement.
But I thought that we can actually see the spleen enlargement because we have the abdominal
Ascites. You also have the abdominal
yeah.
ascites. Yes, that's right. But you can actually see when you do X-ray. Because I don't think you can palpate the spleen because this is basically quite big. But people without ascites, if the patient doesn't have ascites, then if the enlargement, there's no liver enlargement, and usually it's related to the spleen enlargement. Okay, you sometimes see patient has splenomegaly, so this is where you can find the spleen enlargement. Okay, yes, please.
Okay.
Yeah, okay, I
Yeah,
think,
understand, Doctor.
yeah, okay, because you are breaking off. Okay, this is basically looking at learning outcome 1. Irfa, you have anything you want to add?
Just want to mention about the causes, other causes of the ascites
Okay.
other than cirrhosis, which is heart failure,
Mhm.
kidney failure. So basically, the heart failure and kidney failure also will lead to the portal hypertension.
Okay, which type of heart failure?
Congestive heart failure, Doctor.
Right heart
Yeah.
failure, doctor.
Yes, it must be the right heart failure rather than the left. Yeah.
Okay.
Okay. When you talk about kidney failure, how does kidney failure cause ascites?
They
Retention.
ability.
Yes, there's probably an increase in volume, so fluid retention. It also actually causes hypertension because some of the fluid that is supposed to be excreted cannot be excreted, so that's where it's accumulate because of the kidney failure, and usually is related to kidney failure. How about cancer?
Cancer will block the blood flow, right?
Okay, so it depends on which organs they're related.
Yep.
Okay. So infection, we know basically the Hep B, Hep C, they can cause hepatitis. So that can also lead to portal hypertension. Okay, so we are done with the ascites and cholestasis.
Doctor, I have question. Can
Okay.
you hear me? Why does hepatitis A and E does not cause cirrhosis?
Okay, some of this hepatitis doesn't really cause the problem because it doesn't really damage the liver cell as bad as B and C. Usually C is the worst one. Okay, not all viruses will damage the hepatocyte.
Doctor, why we can't have the vaccine for Hep C?
Okay, why we can't? We can. There are Hep C vaccination, but usually the Hep C is due to blood transfusion, or you have a cut that actually go to the what do you call this the vascular route. Then people usually normally do not vaccinate unless you undergo blood transfusion. Then usually you would do hepatitis C vaccination. So they most commonly do either Hep A or B vaccination rather than Hep C. But there are vaccines that actually have A, B, and C types. Yeah.
Okay.
Okay.
Thank you, Doctor.
Why you don't commonly do hepatitis vaccination?
Sorry, Doctor.
Why do we not commonly do hepatitis vaccination as part of the program, vaccination program?
Is it because when we were baby, we already given BCG, then I think it can last for 15 years, but after that is on the individual.
But BCG is not a hepatitis vaccination. BCG is for what vaccination is that? Against
TB,
what?
doctor.
Yes, it's more for TB, not for hepatitis. Okay, so hepatitis is not vaccinated unless you are considered the risk group. Then you are vaccinated. If not, they don't do the vaccination. Okay, but which type of hepatitis that is transmitted to food, oral route? Any idea? So it must be either A or B or
Yeah.
both. Yeah.
Yeah, doctor.
Yeah. That's why C is through the vascular route. That means through cuts or through blood transfusion. So it's either A or B. But B is more common. Usually go for oral route. So then it can be transmitted. Actually, there are many types. They are even up to, I think, A, B, C, D, even up to E, I think. Even F, I can't remember. I think it can go many types up to even F. But the most common one is actually A, B, and C. Is that okay?
Yes, Doctor. Thank you.
Okay. Thank you. Irfan, you want to move to cholelithiasis?
Okay. So for the cholestasis, it is a condition when the flow of the bile from the liver is slow due to the impaired secretion by the hepatocytes, and then will reduce the bile formation, or when the flow of the bile is blocked, it is due to the obstruction of the bile flow, which is in bile duct. And then it is divided into extrahepatic and intrahepatic cholestasis, which is the extrahepatic is happen outside of the liver, which is the bile duct and the pancreas. So the causes is bile duct tumors, narrowing of the bile duct, stones in the common bile duct, pancreatitis, and pancreatic tumor. So basically, from these causes, they cause the obstruction to the bile flow. So for the causes of intrahepatic, it is inside of the liver, which is the alcohol liver disease, bacterial abscess in the liver, lymphoma, primary biliary cirrhosis, primary or metastatic liver cancer, or viral hepatitis. So as we can see here, majority of the causes will cause the reduced bile formation because of the impaired secretion by the hepatocytes.
Okay. Okay, list the causes of abdominal distension. I think we already done that just now. Right. I mean, other than obesity, pregnancy, and all these things, but she is already 50 plus, so shouldn't be pregnant, and it can be due to fat accumulation and all these things. I think that should be okay. Yeah, but most of the time it's due to ascites, and either ascites or mega spleen enlargement or mega splenopathy. Yeah. Okay, then further down. Okay, look at the bilirubin metabolism. You have already done this in your hematology, right?
Yeah, we did in hematology and we did another one in the liver function test.
So basically, you already done this, so you should be able to. You should be very familiar with this.
Yes, doctor.
Yeah. But how do you classify jaundice then?
So there's three classification of jaundice.
Okay.
So the first one is prehepatic. Prehepatic is when the production of bilirubin increases, and the type of bilirubin race is the unconjugated bilirubin. We know that bilirubin comes from your heme. So the causes for your prehepatic is usually because of hemolysis, anything that is related to blood. So like hemolysis, ABO incompatibility, and beta thalassemia. And then the second classification is we have hepatic. There's abnormalities in the liver itself. It's either because of the conjugation process fails, or because of the hepatocyte are damaged, so we can't excrete the bilirubin out from the liver. And the types of bilirubin race is usually unconjugated and conjugated. Why there's unconjugated? Because the failure conjugation process, and for the conjugated is because we can't excrete it. There's a lot of reason causes, such as the Kriegler-Najar And like Crigler-Najjar is usually because of deficiency of UGT1A1 enzyme. This enzyme
Okay.
is, yeah.
And then I just want to add here, because sometimes in hepatic you have a bilirubin conjugated or unconjugated. So your reason is unconjugated because the cell cannot conjugate it.
Yeah.
Hepatocyte can. Whereas the unconjugated because it cannot, those are conjugated because it cannot be excreted.
Yes.
But if the cell cannot conjugate, how can it excrete the conjugate bilirubin?
Because not all parts of the liver are
Yes.
damaged.
Okay, because of the limited number of liver cells that had damage, so it actually prevents some of these liver cells from conjugating the bilirubin, so that's why they are present. Those liver cells or hepatocytes, they're able to conjugate, that's why you have conjugated bilirubin. So it's actually a combination of both.
Yes, doctor.
Yeah. So it's not because of all the liver cells that have been damaged, then you cannot conjugate. That is okay, acceptable, but if there is, then it shouldn't have any conjugated. Unconjugated, they shouldn't have any unconjugated bilirubin. So there will be some hepatocyte that has been damaged. That's why there is no conjugated bilirubin. Then you have hepatocyte that is able to conjugate. Okay, but that sometimes because of the damage of the hepatocyte or the drainage site, so some of these bilirubin, unconjugated bilirubin actually leak into the plasma. Okay, so that's why in hepatic you have both, either conjugate or unconjugated bilirubin is present in the plasma. Is that okay? Yeah. Okay. So yes.
The conjugated one happens to be in the blood because of the damaged cell. It leak out through the damaged cell. Is it, doctor?
Yeah, it leak out from the duct. Okay, you see the lining of the hepatocyte. Some of the hepatocyte that damaged, actually the lining in between that is become the duct for secreting the bile. So some of this bile, because some of this cell in the hepatocyte is damaged, so the formation between this duct there will be leakage. So it actually leak into the capillaries. Can you imagine that? You
Yes,
talk about the
doctor.
triad. Remember about the triad and the flow is counter current.
Yes.
Yeah. Okay. Okay. So yeah, Reina, want to continue?
Okay, so the first causes is Crigler-Najjar or Gilbert syndrome. It is the deficiency of your UGT1A1 enzyme. This UGT1A1, it convert your your GA, your glucuronic acid from your GTP to glucuronic acid so that it could conjugate with your bilirubin. So when patient is deficiency in this enzyme, so he or she fails to conjugate bilirubin. That's why there will be increase of unconjugated bilirubin. So next is hepatitis infiltration. Because of hepatitis or cirrhosis, your hepatocytes are damaged. So like doctor said just now, conjugation process can't occur, and like the conjugated bilirubin will be leaked out. And for metabolic, there are hemochromatosis. This is when your patient absorbs too much iron from his diet. So your hepatocyte is a hepatocyte stores your Fe. So when there's too much Fe stored, it would cause damage to your hepatocyte. Thus, it will lead back to your fail to conjugate and and it will leak out. Next is Wilson disease. It's also the same, but it's just excess copper instead of iron. And then next one is A1 antitrypsin deficiency. This A1 antitrypsin usually will be released when there's necrosis or inflammation to protect your organs. So when there's deficiency in this A1 antitrypsin, your organs aren't protected enough, so your liver can be damaged and would cause your hepatocyte to be damaged. And same goes to your liver malignancy. So that's all for your hepatic. So next one is post-hepatic. So in post-hepatic, your production of bilirubin is normal, your conjugation process is normal, but there is obstruction in your common bile duct or anywhere of your biliary flow. Here is the usual bilirubin race is the only bilirubin race is conjugated because conjugation process occurs normally. So anything that cause your biliary duct to bile duct to be obstructed would be under post-hepatic, such as gallstone, pancreatic tumor, especially at the head of pancreas, because we know if you know the anatomy, then you know where is your common bile duct is located. Primary biliary cirrhosis and also sclerosing cholangitis, all of this would cause your bile duct to be obstructed. So yeah, that's all.
Okay, good. Okay, you want to discuss about the liver function?
Mashita, she's having gastric, so she
Okay.
can't join the
No.
class.
No, it's okay. Anyone want to contribute? I think it's okay. You can read that. Yeah, Rina.
Oh, okay.
Sorry,
I thought
Marcus.
I can like discuss. So,
Sure.
so liver does the metabolic activities. For example, for fat metabolism, the liver cells break down fats and produce energy from it, and also it performs fatty acid synthesis, cholesterol synthesis, and
Okay.
also excretion.
Okay.
Protein synthesis.
Okay, Rina, just we stop here looking at the fat metabolism. So whatever that we absorb from the intestine, okay, this will basically go to the liver. That means what we absorb is basically the fatty acid and also the glycerol, the triglyceride, right? So it will go to the liver, and the liver will basically metabolize or break it down or either combine it to become fatty acid or free fatty or lipids. Then it will be secreted into the plasma. Okay, that's why most of our cholesterol is 70% produced in the liver. 30% is from what we absorb. Okay, so if there's any abnormalities, our cholesterol level will increase, especially when you are, or when people who are above 40 or 50 of age, the cholesterol level increase, even though you don't eat any cholesterol, because the level is produced by the liver. So there's abnormalities in the liver. Yeah. So the other one is the fat. It can also use the fat to metabolize to either produce part of the energy source, basically to produce, or it can undergo gluconeogenesis to synthesize glucose from fat. Okay, so there's a lot of biochemistry there on the liver function. Yeah, sorry, Lucas, you can continue.
Okay, next is the metabolism of carbohydrate. It performs gluconeogenesis, glycogen synthesis, and also breakdown of glycogen to produce energy. Next is protein metabolism. So in the liver, it produces and synthesize the protein and also perform urea cycle.
Do you know what is urea cycle? Any idea about urea cycle?
It's the excretion of the protein through amino acid.
Okay.
Amino acid becomes urea.
It's a nitrogen potion. It's a nitrogen potion. It's an ammonia, basically. It's the ammonia groups of ammonia from the amino acid. The breakdown of amino acid will produce an ammonia group or ammonia molecule. Okay, this molecule is very toxic to the cell. So the liver will basically process it and combine it with carbon dioxide to become urea.
Understood.
Yeah, so they are very important. Why is urea cycle important?
To excrete the excess urea.
Okay.
Because toxic.
Later, when you learn urinalysis, this urea is actually transported to the kidney. When the kidney is filtered and is used for countercurrent mechanism to reabsorb water. or to
Oh, I
concentrate the
see.
urine. Yeah. So there are many cycles that they are important. And if people who are diabetic and they do not take in any glucose, let's say they do not take any carbohydrate or glucose, where do you think the glucose will come from?
From the protein and fat.
Yeah, actually from the gluconeogenesis, that means from the fat and also from the protein part, they actually generate the glucose and produced actually by the liver. Okay, does the skeletal muscle also store glycogen, contribute to the plasma glucose level?
Yes.
No. Okay, the
Oh,
answer
no.
is no. So the glucose level is only contributed by the liver, even though the glycogen, there is actually a lot of glycogen stored in the skeletal muscle. But the glycogen stored in the skeletal muscle is only for the skeletal muscle usage only. So it does not convert into glucose that is secreted into the plasma. Yeah, but the liver, yes, liver is the one that actually maintain our plasma glucose level. Okay, yeah,
Okay,
yeah,
understood.
okay. You can continue.
Okay, and then we have hormones metabolism, where we metabolize steroid and polypeptide hormones. Okay, next is the liver function for nutrients, medication, and also toxic substances, which is carried by the blood, are processed, stored, altered, detoxified, and passed back into the blood or released in the bowel to be eliminated.
Okay.
Next is the breakdown of old and damaged blood cells. And
Okay.
lastly, to produce bile continuously. However, it accumulates between nails and is stored in the gallbladder, which also concentrates the bile by absorbing water and salt. As it arrives in the duodenum, the gallbladder sends concentrated bile through the biliary duct to the duodenum.
Okay, what hormones cause the bile duct to express or to secrete bile into the duodenum? Anyone? What hormones stimulate the gallbladder to secrete the bile into the duodenum? When
Is
there's
it
a
CCK, doctor?
yes, it's CCK. Okay, remember that CCK actually cause the gallbladder, which have a small muscle, to contract and basically express the bile into the duodenum, yeah, or secrete the bile into the duodenum. Okay, now the other question I will ask you is, what plasma protein is produced by the liver in protein metabolism? And these are very important. Yes, albumin. So this is very important proteins that is produced by the liver. Okay, what is albumin for then?
For the transport.
Okay, it can act as a transport protein to transport insoluble substances. But the most important thing is basically to maintain the oncotic pressure in the plasma. Okay, so what happens if the liver is not able to produce, or there's a damage to the liver and is not able to produce the albumin?
Bilirubin can't
oncotic
be transported.
Okay, yeah, Renia?
It's okay, Awni first.
Sorry.
low oncotic pressure.
Yes, what happens when the oncotic pressure is low?
So the fluid will leak out into the plasma and then cause abdominal cavity to enlarge, ascites.
Yes. So which means that that patient has ascites is due to low albumin that is produced because of liver cirrhosis. Is that right?
Yes.
Yes. So this is the reason also why the patient has ascites, because of liver cirrhosis, because there's not enough albumin that is being produced to maintain the oncotic pressure in the plasma. So actually the oncotic pressure is lower. Even the hydrostatic pressure is normal, but we just now discussed saying that because of the portal hypertension, it caused the leakage. Yeah, Yufa, is that right? So now we add another factors that also can cause ascites in the patient. There is low albumin.
Okay, doctor.
Okay, so there's another factors. Yeah, so we are done with the liver function. So you can see that the liver actually do many functions for us. So sometimes this is considered one of the most important organs that help to detoxify all the nutrients or all the toxins that come into our body. Okay, before it go into the normal circulation. Yeah, or systemic circulation. So I think the anatomy side you all should be okay lah, unless you all want to go into it. If not, we will just move on. Okay, so you just move on the anatomy side. You can because along basically you need to memorize and also the histology. You can look at the triad, yeah, and describe the histology. Okay, I think you can look at the triad and how the blood circulation. Unless you have good pictures that you want to show. No. Okay. So we move on to pathophysiology of the sign and symptoms.
Okay, so first is for the abdominal distension. So this liver cirrhosis can cause increase in hydrostatic pressure and decrease in oncotic pressure in the vein that drains into the liver via the portal vein.
So you know
So
now why there's a decrease in oncotic pressure in the vein.
yeah, because of the low albumin in the blood. And
Yes.
for the increased hydrostatic pressure, it's because of the scar tissue that blocks the blood flow.
Yes.
Okay, then this will leak the fluid into the abdominal cavity and cause ascites and abdominal distension. So for the yellowish sclera, it's because of the both conjugated and unconjugated bilirubin. So liver cirrhosis can cause both of the bilirubin to produce because first some damage to the hepatocytes happen. So this will cause some part of the liver to lose the ability to conjugate bilirubin. So the unconjugated bilirubin will remain in the bloodstream because they are bound to albumin and are insoluble. And then for the second one, liver cirrhosis can also compress the intrahepatic bile ducts, which will decrease the hepatic clearance. So the bilirubin that are conjugated already will also remain in the bloodstream. So these both will cause yellowish sclera because sclera contains elastin, which has high affinity for bilirubin. And then moving on for the grayish stool, this is for the conjugated bilirubin. It's because the liver cirrhosis compress the intrahepatic bile ducts, so the conjugated bilirubin cannot go out into the intestine. So the conjugated bilirubin will remain in the bloodstream. So when it does not go out into the intestine, the conjugated bilirubin will not oxidize into stercobilin. And stercobilin is important because it gives the stool its brown color. So when there is no stercobilin, not enough, so the stool will become paler, which is greyish. So for the bleeding while brushing teeth, this liver cirrhosis can cause thrombocytopenia, like in the test, and also less clotting factors from the high protothrombin time. So for the thrombocytopenia, it's because of the reduced production of TPO. So reduced production of TPO will the megakaryocyte, there is less megakaryocyte that can differentiate into platelet, causing thrombocytopenia. So from the thrombocytopenia and less clotting factors, this will cause the poor blood clotting, which will make the gum to bleed easily. So for the prolonged loss of appetite with lethargy, liver cirrhosis, like as we see above, it can cause ascites, abdominal distension. So this will stimulate the vagal afferent mechanoreceptor because there is abdominal distension. And this will activate the satiety center at the hypothalamus. And from the activation, it will inhibit the feeding center, making the patient lose appetite. So for lethargy, the liver cirrhosis, makes it easier to bleed. So there is low hemoglobin because low RBC. So this will cause anemia and cause lethargy. For the second one, the liver cirrhosis can also cause unable to store glycogen, as Balkis has said just now. Unable to store glycogen, which make the muscle tissue is used for energy between the meals. So this will cause weakness. And then for nausea, the liver cirrhosis can make it cannot function normally, so it cannot remove the excess waste products in the body. So this is a metabolic disturbance which will stimulate the chemoreceptor trigger zone and activate the vomiting center, making the patient nausea. And then the last one is problem sleeping at night. The liver cirrhosis will increase blood ammonia, so there is toxic effect to the pineal gland. This will change because the melatonin is from the pineal gland. So this will change the melatonin secretion patterns. Actually, melatonin is secreted peak at night. So when there is change in the pattern, this will make a delay in the peak of the secretion. So at night it will become low and then high in the morning. So that is why it is hard to sleep at night because low melatonin. Thank you.
Doctor,
Sure. Yes.
is it possible the reason why the patient is hard to sleep at night because of like ascites and then the gravity and then the lung can expand properly? Is it possible because of that?
Yeah, it's possible because it might actually fill the lung because of the excess fluid in the peritoneal cavity, which might actually get into the lung. So he might have difficulty breathing. But in this patient, it was not mentioned, so we do not want to go into that.
Okay, doctor. Thank you.
Okay, so most of the thing the patient couldn't sleep at night is because of what I've been experienced due to the presence of ammonia, because the liver is a site where you actually detoxify the ammonia with carbon dioxide to become urea. So because of the damage to the liver, this function cannot be done. So there will be increase in actually blood urea nitrogen or blood urea basically, yeah. Okay, so the causes of chronic liver disease.
Okay, so I'll be explaining the causes, chronic liver disease, but I think it's better for us to understand first what is chronic liver disease. Basically, the progressive deterioration of liver function for more than. Yes, Balkis, sorry.
No, I wanted to ask Dr. Hafiz about one of the symptoms just now. Sorry,
Okay.
Doctor, it's about the anemia. Does the patient experiencing with bleeding to present with anemia?
Okay, why the patient has anemia? That's what you mean.
Yes.
Is it due to the breathing? Is that right?
Yes.
Yeah, that could be
does the
one of
patient
the
have,
gum breathing. Yes.
so
The
so
gum,
the so the gum bleeding actually cause anemia, Doctor?
no, that is not the main cause. Okay, gum breathing can lead to, but if unless it's very chronic, that means you have been breathing constantly, then yes. But the most important thing, the liver is not able to produce the necessary amino acid for the RBC to function properly, or to basically the bone marrow to function properly. So that probably reduce the number of RBC that can be produced. Okay, so with the breathing, the gum actually contribute to that. So some of this, even the liver is not able to produce that necessary amino acids there for the formation of the RBC, then most of these RBC might be formed anomaly. So a lot of them actually will undergo destruction if they are not well-formed RBC. So that also can lead to anemia. Is that okay? Do you agree? No.
I think I think it's okay for the Indian case. the blood cannot be formed properly because of lack protein produced by the liver. But to say that the patient have anemia because of some bleed, I think kind of misleading.
No, is probably can contribute, but not the major cause. Okay, so the gum bleeding can be the one of the causes, but not the major cause. It's more due to the liver function that is not able to produce enough RB, I mean the amino acid that is necessary for the RBC formation. Yeah, and even the RBC that is formed that might be deformed, so it probably lead to also increased RBC breakdown. Is that okay?
Okay, thank you, Doctor.
Okay. Sorry, who is that? Hainani, you want to continue?
Yeah, sure. So for the causes, chronic liver disease. First, what is chronic liver disease? Basically, the progression or deterioration of liver function for more than 6 months. That's how we categorize chronic liver disease. And then I think it's very important for us to understand the general pathophysiology because to relate the causes and how it becomes chronic liver disease. Basically, the causes we cause inflammation to hepatocytes, and constant inflammation will damage the hepatocyte. This will cause the formation of scar tissue, which is fibrosis, and then will lead to the cirrhosis. Cirrhosis is the chronic stage of liver disease. So, what are the causes?
Yes,
First, we have
Hainani, just one question. Will the liver cell able to regenerate after it's been damaged?
if cirrhosis, I think cannot because too much hepatocyte has been damaged. But in the early stage, yes, it
Yes.
can regenerate.
And we have to be very sure that if you cut off some of the liver and donate, let's say part of the liver, your liver can regenerate back the portion that you cut off. So
Yes,
the liver can regenerate, yeah. But somehow because of this case, the patient have been constantly assault, yeah. And that cirrhosis is due to the infection, the viral infection. Okay, so it has not enough time to basically regenerate back the damaged hepatocyte, yeah.
agree, doctor.
Okay, thank you. So you can continue.
Okay, for the causes, first we have viral hepatitis, just like our case. Uh, for viral hepatitis, we have from A, B, C, D, E, but we have to take note that only B, C, D that can lead to the chronic state. Hepatitis A and E will not proceed to the chronic state. And then we have fatty liver disease. Fatty liver disease, for the name itself suggesting there's too much fat stored in the hepatocyte, which too much when there are too much fat in the hepatocyte, it can lead to the inflammation and will proceed just like I have mentioned above. And for fatty liver disease, we have two types. First, we have alcoholic fatty liver disease, and alcoholic, okay, supposedly in alcohol abuse, because alcohol itself will cause the accumulation of fat in the liver. And for the non-alcoholic fatty liver disease, we can see in the many cases such as obesity. And then autoimmune hepatitis, basically when the antibody attack the our own body cell. And then primary biliary cholangitis, basically because of the inflammation of the duct, it will backflow to the liver, and it will accumulate the bile in the liver, and this will cause the inflammation to the liver and will proceed to the stages that I have mentioned. Okay. So for the stigmata, basically, Balkis mentioned in our pre-TVL that this quite many, right, and long. Basically, all the stigmata in my discussion from Progress 2 and Prof 90 class. I think we go by, because I didn't, my bad lah, I didn't arrange based on like from hypertension, fibrosis, anemia. So I think Rania can help me later. But first, let's go to the jaundice and yellow sclera. Basically, jaundice and yellow sclera. Actually, Rania have been discussing this just now, because of the and Auni too, because of the necrotic hepatocyte. Thus, we cannot conjugate the bilirubin, and this will cause the accumulation of bilirubin in the blood, and the bilirubin will give color, yellow color, to the skin and yellow sclera. And basically, we need the bilirubin to be conjugated so that we can excrete from our body. And then we will go to the anemia. So the first one is conjunctiva, and it is usually connect with the anemia, because the first, because of the deficiency of coagulation factor. As we know, coagulation factor is being synthesized in the liver. So when there is a lack of coagulation factor, it will cause the anemia, and anemia will cause the conjunctiva. The second one is the alteration of erythropoietin. Basically, EPO usually being produced in the kidney. For That's for large amount, but liver also produce EPO in a small amount. So it also play a role in producing RBC. So another thing about anemia is, Rania, can you scroll down Echinosis? I think it's number 13. Okay. Basically, echinosis also because of the coagulation factor, defective of coagulation factor, and that's why we can see the blood uh, on superficial. Okay, so I think we can move to the hypertension. So the first one, Capit Mendoza. Can you find it for me, Capit Mendoza? Okay, thank you. So, for Caput Mendoza, basically because of the inflammation of hepatocyte, and then causes the portal hypertension, and then this portal hypertension will shunt the blood. Ryan, can you scroll onto the second picture? So as we see, can you zoom a bit? Uh, okay. So as we can see from the picture, the because of the hypertension from the portal vein, it will backflow to the one of the vessel is called para-umbilical vein, and from the para-umbilical vein, it will go to the vein at the superficial of abdominal wall, and this when this the superficial vein swollen because of the backflow from the vein, portal hypertension, and that will cause the caput medusa. And the other thing from the hypertension, it will cause the spleen enlargement. Can you move the spleen enlargement, please? Okay, so basically, from the portal hypertension also, it can backflow to splenic vein, and when it backflow to the splenic vein, it will as we know, spleen play roles in destroying platelet, white blood cell, and RBC. So when it get too much blood, then it will destroy much more, and this will cause hyperplasia, and that will cause the enlarged spleen. And then we can move to fibrosis. Can you go to Dupuytren contracture? Okay, so basically, this because of the proliferation of fibroplasia at the palmar and digital fascia, and because of the fibrosis there, it will cause the contracture of the finger. So so I cannot find the solid one what caused the fibrotic formation of fibrous tissue, but basically what there's suggestion that say it because of the damage of fatty tissue and because of the released free radicals from the inflammation. And then also fibrosis, another thing under fibrosis, it can cause ascites and cirrhosis, but I don't think that I have to explain that as we have been discussing that since early. Then we move to the production. Can we go to the clubbing finger? Okay. Okay, so clubbing finger basically because of the inflammation, it will activate the megakaryocyte and platelet, which this will release platelet-derived growth factor and vascular endothelial growth factor. And from these two, it will increase the blood flow and capillary permeability at the fingertip, and that will cause the interstitial edema at the fingertip. Thus, it will form the clubbing finger. And then another one is Lyconia, Lyconia. Okay, so basically, Lyconia, because of the hypoalbuminemia. So what's that?
Yeah, no, it's okay. It's Lyconikia.
Lyconicia. Okay, so
Lyconikia.
thank you, Doctor. Lyconicia is another, we call it as white nails, basically because of hypoalbuminemia. So one of the way we want to see the patient in with hypoalbuminemia, we look at the finger. We look at for this Lyconicia, and as we know that albumin is purely synthesized in the liver, so damage to the hepatocytes will cause the albuminemia. And what else? Okay, a breakdown. So can we go to palmar erythema? Okay, so basically because of as I mentioned, just now I explained about the spider nevia, and for palmar erythema, it also because of the estrogen, because of the free estrogen, which is it's supposed to be metabolized in hepatocyte in liver, but because of the damage to the liver, it cannot be metabolized. Thus, it will cause the increased free estrogen and increased vascularity. Another thing that estrogen can give sign is by I think some number apa ni? 8. Is it 8 or 7? Gut. Sorry. Sorry, 12. I don't really a bit lembab sikit nak baca nombor-nombor macam ni. Okay, so this one is gynecomastia. Basically, the enlargement of the breast tissue in males is also because of the failure to break down of the estrogen. And I want explain again for the spider nevia as I have presented just now. And the next one is factor, the below one. The factor hepaticus is basically we can smell the breast with the breast is with the strong musty smell. It's basically because of the liver cannot filter out the toxic substance. As we know, the liver one of the function is to um, filter out the toxics. So when it fails to do so, it will the toxic will go out in the bloodstream, and it will go to the lung, and that's why the breath become very smelly. And then the last one is hysteresis. Um, can you guys see the slide, or it's just me? The slide a bit hang. Okay, thank you. For this one is basically hysteresis is a tremor of hand when the patient want to extend the wrist. So and we can see it as bird flipping their wings. So this because of liver also fail to metabolize toxins and ammonia, which ammonia is supposed to metabolize into urea to be excreted, but failure to do so, toxin and ammonia will go to the brain and will cause the brain damage and will cause the motor disorder. Okay, so that's all from me. Thank you.
Okay, thank you. There's a long explanation on all these signs and symptoms. Kan?
Can I ask a question?
Okay.
Firstly, the patient doesn't have dialysis that it can like
So you are breaking off, Balkis.
Or maybe Balkis can type in the chat. We can read it.
is it breaking? Hello.
Now it's okay. Now it's okay.
Now, okay.
Okay. I asked that this patient doesn't have hysteresis, right?
No.
Okay. And then the next question. What kind of smell is musty smell?
Sorry. Can you just break for a while? No, it's okay. Sorry, Balkis, you talk about the musky cell smell.
Smell, yeah.
Yeah.
Like, how is it like?
Anani, how does the musty cells smell like?
I think it smell like damp, moldy damp. It's basically bad smell lah. It
Okay.
give a bad smell.
If you happen to stay beside a cat that has cats or dogs, usually the dog will smell very badly. There's a musty smell. If you happen to go somewhere and there's a dog that is, let's say, having a skin problem, then you can actually smell the musty smell. So it's like a fungal, or you go into a room, basically there is a fungal smell in the room and it's not ventilated. That is type of smell. Plus also purity smell, basically. Is that okay, Balkis?
Okay.
Yeah, it's quite difficult to describe. Basically, you have to experience that.
I think I can imagine how it smells like. And another thing, how like hypoalbuminemia or albumin in the blood can cause like white patches on the nails. Because
Okay.
I think it's pretty frequent for anyone to have like those white.
Okay, Hainani, you want to explain why there is a white patches under the nail? Yeah, the
Okay,
one.
actually for this one, I also tried to Google to find the answer, but honestly, I don't really found the answer why it gives the whitish one. But it's basically in this picture. It's basically it's not that bad. But actually, in we can find there are patients with very almost the entire nail whitish. So. And I'm so sorry, I can't give the reason why it gives the white color. Sorry.
Okay. Most of our nail is basically growing every day. If there is lack of this albumin, that actually affect the growth of the cell. Okay, so the growth seem to be affected. So that's why there's a lot of this white deposit on the skin under the nail. Okay, so those who have very serious liver, this is very mild, actually very mild. So those who have very serious liver cirrhosis, basically the nails is basically almost white. Is that okay? Okay.
And Balkis, basically, I found that because it's very common for people to have the white teeth a bit whitish on the nails, right? One of the reason is because of the injury. The injury to the nails can cause the whitish. That's what I read.
Yeah, because the same thing as this, somehow the damage to the liver cell also affect the growth of the cell under the fingernails. So that's why that is the problem. So you see that there's actually a retarded growth. That's why it become whitish. The line. Same thing as Hainani said, just that if we happen to have not sometime at the fingernails, so there's some injuries, and this will only shows like 1 month later when the nails start to grow forward, then you can see the whitish patches. Is that okay, Wakis? Okay, yeah. So, yeah, now it's your turn to talk about the lab investigation.
All right. Number 10, interpret the lab investigation according to the progress tree. So the abnormality or derangement here is the low hemoglobin. So this indicates anemia, which is very, very common in patients with liver cirrhosis. And in United States, where they record 75% of cases of liver cirrhosis have anemia. So anemia in liver cirrhosis is multifactorial, which means that it can be caused by different types of factors, and most common complication accounted. So hemoglobin levels can also decrease with an increased severity of the liver, and liver failure can cause the inability to produce enough amino acid to produce proper red blood cell. Next is low platelet, or in other words, is thrombocytopenia, which also thought to be multifactorial. Besides that, it is also inducing an autoimmune reaction with production of anti-platelet antibodies. So basically, this anti-platelet antibody attack the platelet and cause the decreased amount of platelet in the plasma. And then the virus also cause direct bone marrow suppression, with resulting of thrombocytopenia. Chronic hepatitis C virus infection can induce liver fibrosis and also cirrhosis, which then lead to portal hypertension with subsequent hypersplenism and sequestration of platelet, decreased production of thrombopoietin, endothelial dysfunction, which all can contribute to thrombocytopenia. In cases of chronic liver disease where cirrhosis exists, the platelet count can be lowered, although this can occur to many conditions other than liver disease. Okay, next is the LFT, or the liver function test. So why do we check for LFT? First is to confirm a clinical suspicion of potential liver injury or disease. And next is to distinguish between hepatocellular injury, such as hepatic jaundice, and cholestasis, which is post-hepatic or septic jaundice. So based on the report, we have low albumin, which can be reduced due to liver damage and kidney disease, because albumin is made in the liver, and the level tends to drop when the patient has cirrhosis. The next one is high total bilirubin.
How does kidney disease contribute to low albumin level? Yeah. Okay. Now, if the patient have kidney disease, basically it causes the leakage of albumin. So you're actually losing a lot of albumin into the urine. So this is excreted. That can actually lead to liver low albumin level. Okay, because albumin is not being filtered in the kidney, but if there's a damage to the kidney, then all this large protein, the albumin, will be filtered out. Then it will be lost in the kidney, in the urine. It will be excreted together within the urine. Okay, yeah?
All right.
Yeah.
Okay, and then next one is high total bilirubin, which is an elevated level of conjugated and unconjugated bilirubin. So what is the causes of unconjugated hyperbilirubinemia, which includes hemolysis, such as hemolytic anemia, impaired hepatic uptake, such as drug and congestive heart failure, impaired conjugation, such as Gilbert syndromes, and also cirrhosis, which can cause in this case is the cirrhosis, which is caused by unconjugated hyperbilirubinemia, as hepatic fibrosis, which leads to capillarization of the sinusoids, causing decreased bilirubin uptake by hepatocytes, and also other multifactorial etiologies such as chronic hepatitis, which is associated with unconjugated hyperbilirubinemia. So causes of conjugated hyperbilirubinemia includes hepatocellular injury, hepatitis. So hepatitis can be caused by different etiologies, for example, virus, alcohol, and also autoimmune, which all is associated with conjugated hyperbilirubinemia. And lastly, is the cholestasis. So the table below is to show you that unconjugated is also known as indirect reacting bilirubin, and conjugated is direct reacting bilirubin. And it lists the table 4 lists the common causes of isolated bilirubin elevation. So in this case, if the direct reacting bilirubin is elevated and the indirect reacting bilirubin is normal or elevated, it means that it's a liver disease of Pennetites. Okay, go down. Okay, so in this patient, we have high ALP, or called as alkaline phosphatase, which is the family of enzyme produced in the bile ducts, intestine, kidneys, placenta, and bones. So these levels may rise when disease of the bile ducts or bone disorder occur. So this is a very useful indirect marker of cholestasis. The next is high ALT, which is enzyme produced in hepatocytes, the major type of liver cells. ALT level in the blood is increased when hepatocytes are damaged or die, which is caused by different types of hepatitis, viral, alcoholic, drug induced, which all can cause hepatocyte damage. So how do we compare ALT and ALP levels? So if there is a greater than 10-fold increase in ALT and a less than 3-fold increase in ALP, then it suggests a predominantly hepatocellular injury. And if there's the next one is a less than 10-fold increase in ALT and a more than 3-fold increase in ALP, this suggests cholestasis. The last one is it is possible to have a mixed picture involving hepatocellular injury and also cholestasis. So the last one is the high AST, which is also similar to ALT above, but less specific for liver disease because it is also produced in muscle cells. And then how to check for the ratio between AST and ALT. So if the ratio is identified, it can determine the likely cause of LFT derangement. So if LFT is greater than AST, is associated with chronic liver disease. If AST is greater than ALT, is associated with cirrhosis and acute alcoholic hepatitis. And then the hepatitis serology. We have hepatitis B antibody. is detected in this patient. So probably this patient is vaccinated or have previous infection. And then we also detect hepatitis C virus antibody, which is reactive. So anti-hepatitis C virus antibody could take about 8 to 12 weeks before results are positive, which is the duration after exposure. So this test detect antibodies to HCV and are used for screening and diagnosing HCV infection. So the result can be reported as positive or negative in values. So if there's a negative value in the test, so it is sufficient to exclude a diagnosis of chronic HCV infection in immune competent patient. Those on hemodialysis and patients with immune deficiency may have false negative, whereas false positive may occur in patients with autoimmune disorder. Okay, the next one is the confirmatory test for HCV. So in this patient, we have a positive HCV RNA. So after an acute HCV infection, HCV RNA could be detectable in the serum within 2 weeks following exposure. So if we do a qualitative test, then we will detect only the presence of the HCV RNA with the specificity of 98%, whereas quantitative assay, which detect the viral load in the international unit per milliliter, which has the specificity of approximately 99% and provide adequate information that guides clinicians to manage and monitor treatment outcomes. And we have HCV genotype test, and then we have detected that it is genotype 1, which is the most common type. Okay, so it determines the specific subtype of the virus. This is very useful in guiding the treatment. All HCV genotypes cause the same amount of liver damage. However, people infected with genotype 1, particularly subtype 1B, may have greater chance of developing cirrhosis or severe liver scarring other than other genotypes. Genotype 1B and 3 may increase the risk of liver cancer. Lastly, the coagulation profile. We have a high APTT, which is the clotting time. And this is caused by serum fibrinogen potency and platelet count were significantly reduced in cirrhosis patients because the liver were unable to produce or synthesize clotting factors.
Okay, thank you. The next one, mode of transmission and pathogenicity of HCV.
Okay, so I'm going to be sharing about mode of transmission and HCV pathogenesis.
So this
it's
is only
what...
about HCV. Are you going to talk about HCA?
I did for HCV only.
Oh, only HCV, okay. You don't talk about HB, hepatitis A, B, and but also the D, E, no.
No, but we did learn in Prof. Salah's class.
Okay.
Yeah.
So focus on HCV first.
Yeah.
Okay.
Okay, so this is what I found, what I got from Prof. Salah's class also. So it's kind of a revision. So for the mode of transmission of HCV is the main one is blood-borne parenteral, which is the most common, but we also have other non-common mode of transmission. So blood-borne will be by sharing infected needles with a carrier based on in drugs, or the reuse or post sterilization of injection equipment, and also blood transfusion, mainly for the unscreened blood or any blood products, and also accidental exposure to infected blood. So the other non-common ones is non-parental, which is based on sexual transmissions with a high-risk individual, and also from infected mother to a baby during delivery. And we have to remember that HCV is not spread through breast milk or food, water, or any casual contact such as hugging, kissing, sharing food and drinks with an infected person. So the pathogenesis of HCV, first we have to know that HCV is a non-cytopathic virus, meaning that this virus itself does not damage the cells or kills the hepatocytes, but then what kills the hepatocytes is the immune attack of our body by cytotoxic T cells. So how does it happen? So HCV assembles and is being released from the infected cells, and then the encoded proteins of HCV will help the virus to escape innate immune response, which is the macrophage and all of that lah. So our body will get acquired immune response, which is by CD8 T cells, which helps to eliminate HCV by apoptosis of infected hepatocytes. And also there will be interferon gamma, which inhibits viral replication. And basically, this acquired immune response is the one who will heal, not really heal, make it resolve lah for the acute infection. But then we also have TNF alpha, which causes hepatic injury and will trigger cytokine storm, which will then cause liver damage in chronically infected patients. So as you can see the diagram down there, I have placed a diagram. Can you see? Okay. Okay, in that diagram, we can see like, okay, after exposure to HCV, we will be in an acute phase. So there will be chances of being resolved or it leading to another chronic infection. So from the chronic infection, it can be stable or then leads to cirrhosis. And from the cirrhosis, it can be slowly progressive or it goes to hepatocellular carcinoma. But here in chronic HCV, naik atas please. Okay, so in chronic HCV, there will be a promotion of insulin resistance in hepatocytes by increasing inflammatory response due to the expression of TNF alpha, interleukin 6, and also oxidative stress, which will then lead to the progression of fibrosis and hepatocarcinogenesis. And to know whether it's chronic HCV, you can see a characteristics of portal inflammation, especially periportal hepatocellular inflammation, and also fibrosis. So basically, that's about HCV and the pathogenesis of it.
Okay, so we move on to the next one. Yeah, causes and pathogenesis of the liver disease. I think by now you all should be familiar about how this basically finally developed to become liver cirrhosis. And Shafika says that the damage is not because of the virus, it's more due to the immune cell actually attacking the hepatocyte that is infected with the virus. Right?
Okay, so for my part is the causes. First, we know that liver cirrhosis is the late stage of scarring of liver, which causes by a lot of diseases and conditions. One of the most common is chronic alcohol abuse, chronic viral hepatitis, which is in this patient is hepatitis C, primary biliary cirrhosis, primary hemochromatosis, and Wilson disease. Chronic viral hepatitis is also the main disease that causes liver cirrhosis in Malaysia. So when the hepatocytes are constantly damaged and become fibrotic, it forms a scarring which is known as cirrhosis. So how does this happen? Can you scroll down a bit? Okay, so when the hepatocytes are injured, like Shafika said, it was because of the immune system that is caused by the infection of hepatitis C. It produces a parenchymine factor. In this case, it's the TGF beta, which activates stellate cells that sits in the perisynovial space or space of this. The cells will proliferate and it will lose its vitamin C and form myofibroblasts and produce a collagen scar. This collagen and fibrotic tissue will surround the regenerative nodules, which is basically the classic sign of liver cirrhosis. And this all will lead to liver cirrhosis. So stellate cells in a healthy state basically stores vitamin A and it usually remains dormant and it helps in wound healing. So when the hepatocytes are constantly injured, it will become activated constantly and tries to repair, which then will lead to the production of fibrotic tissues and collagen. So it can also lead the complications since it always constantly producing the fibrotic tissues and collagen for repair. It builds up in the perisynovial space and it will eventually compress in the sinusoid and obviously the lumen of the sinusoid will become so narrowed, the blood pressure will increase. This is known as portal hypertension. That's all from my part.
Okay. Hi everyone. My question is to describe the growth and the histological features of liver cirrhosis. So, according to grossly, when you view a cirrhotic liver, it appears to be nodular pulp node on the external surface, and on the gut surface it's also nodular. And there are variations in the size, color, shape, and consistency, and this is relevant in helping to identify the etiology. Also, the World Health Organization has classified cirrhosis into 3 categories based on their morphological characteristic of the hepatic nodules. The first one is the micronodular cirrhosis, and usually in this, the nodules are less than 3 millimeter, and that is how you identify that. We also have macronodular cirrhosis. In here, the nodules are usually larger, and they are more than 3 millimeter, and can even be up to centimeters. And their diffuse are more irregular than micronodular cirrhosis. And for the last one, we have mixed nodular cirrhosis. This is a mixture of both types. Like I said, it's classified based on like the size of the nodules, and that is how you classify them. So for this one, it has like a mixture of both, and only a few portal tract and central vein are involved. And the cut section of the liver usually shows nodular appearance. Size of each nodule varies from 1 millimeter to 10 millimeter, and the normal architecture of the liver parenchyma has been distorted by these nodular formations. And both of the capsular surface and the cut surface show coarse nodularity of varying sizes and shapes. And this is due to hepatocyte necrosis, regeneration, and fibrosis. And this condition is called mixed nodular cirrhosis of the liver. So the most common underlying cause for this is alcoholic liver disease, and other causes include viral hepatitis, biliary diseases, hemochromatosis, Wilson's disease, and others. Okay, so for the histological description. Okay, so you can see thick bands of fibrous tissues replacing the tissue between the portal tracts, and there is an abnormal liver architecture. You can also cite regenerating nodules. The fibrous tissue bands surrounding surviving hepatocyte, and they attempt to regenerate to form parenchymal nodules, and also the hepatocytes exhibit dimorphism, dysplasia, hyperplasia. I've attached picture of a normal liver histology, and also for one with liver cirrhosis, and you can see here, and nodules are surrounded by the fibrous tissues. Okay, also next picture. the nodule of regenerative and hepatocytes can be seen here, and also the thick bands of mature fibrous tissues can also be seen there. There's a label there. All right, yeah, that's all for my part. Thank you.
Okay, thank you. So drugs, what are we going to do with the patient?
For her so hypertension, the doctor prescribed her diuretics and beta blockers.
Why
So
diuretic is given?
volume of water, the volume of the blood, correct?
Sorry?
To decrease the volume of the blood
Okay.
and decrease the reabsorption to enter the bloodstream.
It's actually to reduce the fluid in the abdominal, peritoneal fluid, the ascites.
Oh, okay.
Okay, so you can give either thiazide diuretic or loop diuretic, yeah? Or you can actually give both, but you have to be very careful to monitor the blood pressure because you do not want the blood pressure to drop too much.
Should I continue explaining the types of diuretics, doctor?
Yes, please.
Okay. Okay. There are three types of diuretics. First one is thiazide diuretics, which exert their diuretic effect by blocking the sodium chloride channel in the proximal segment of the distal convoluted tubule. When the sodium chloride channel is blocked, decreased levels of sodium cross the luminal membrane, thus decreasing the action decreasing the action of the sodium-potassium pump and decreasing sodium and water passage to the interstitium. Next is the loop-acting diuretics. The loop diuretics induce its effect by competing with chloride to bind to the NKCC2 cotransporter at the apical membrane of the thick ascending limb of the loop of Henle and blocking the cotransporter, which inhibits the reabsorption of sodium and chloride. By inhibiting the sodium chloride reabsorption, tonicity in the interstitium decreases, and free water excretion increases as a result. Blocking of the NKCC2 cotransporter makes potassium unable to be reabsorbed back into the lumen, which results in loss of calcium and magnesium ions. Next is the potassium-sparing diuretics. These diuretics do not directly act on the sodium transport. They antagonize the actions of aldosterone receptor antagonist, at the distal segment of the distal tubule. This causes more sodium and water to pass into the collecting duct and be excreted in the urine. They are called potassium-sparing diuretics because they do not produce hypokalemia like the loop and thiazide diuretics. The reason for this is that by inhibiting the aldosterone-sensitive sodium reabsorption, less potassium and hydrogen ions are exchanged for sodium by this transporter, and therefore less potassium and hydrogen are lost to the urine. Other
Why?
potassium...
Why is it important to use the potassium-sparing diuretics?
Is it to prevent hypokalemia, doctor?
Yes. Yes. Because you do not want to have any effect on the heart. If you lose too much sodium, it can cause hyperkalemia, so it can cause the heart activities to increase. So it can cause palpitation. Yeah? Sorry, and also muscle contraction. So you have to be very careful when you talk about potassium. Yeah, because the potassium in the ECF is very low. It's only 4.5 to 5 millimole. Yeah. Okay. Sorry, Jory. You can continue.
All right, thank you. Other potassium-sparing diuretics directly inhibit sodium channels associated with aldosterone-sensitive sodium pump and therefore have similar effects on potassium and hydrogen ion as the aldosterone antagonists. Their mechanism depends on renal prostaglandin production. Because this class of diuretics has relatively weak effects on overall sodium balance, they are often used in conjunction with thiazide or loop diuretics to help prevent hypokalemia. Next, the other medication that was prescribed by the doctor to the patient is beta blockers. First, the catecholamines and epinephrine and norepinephrine bind to beta-1 receptors and which increase cardiac automaticity as well as conduction velocity. Beta-1 receptors also induce renin release, and this leads to an increase in blood pressure. In contrast, binding to beta-2 receptors causes relaxation of smooth muscles along with increased metabolic effects such as glycogenolysis. Beta blockers act as a competitive inhibitors of catecholamines, exerting their effects at both central and peripheral receptors. Blockade of beta receptors result in decreased production of intracellular cyclic adenosine monophosphate, with a resultant blunting of multiple metabolic and cardiovascular effects of circulating catecholamines. Beta-1 receptor blockade reduces heart rate, blood pressure, myocardial contractility, and myocardial oxygen consumption. Beta-2 receptor blockade inhibits relaxation of smooth muscles in blood vessels, bronchi, the gastrointestinal system, and the genitourinary tract. In addition, beta-adrenergic receptor antagonism inhibits both glycogenolysis and glyconeogenesis, which may result in hypoglycemia. There's two types of beta blockers, the beta-1 selective and non-selective. Non-selective affects both beta-1, beta-2, and beta-3 receptors.
Is the patient given beta-1 blockers? Is this patient given beta-1 blocker? Yes, Julie. Is the patient given beta-1 blocker or beta-2 blocker, as what you described?
I think beta-2 blocker, doctor.
Or was given beta-2 blocker?
But I'm not sure.
Okay, any other drugs that was given other than the beta blocker and also the diuretics drug?
Based on the progress report, they only mentioned diuretics and beta blockers.
Okay, are they giving any antiviral drugs, or how are you going to treat the hepatitis that the patient is suffering? Sorry, Jolie.
Okay, they didn't mention antiviral drugs. They only said that further testing to determine the best treatment on HCV.
Yeah, actually you should also explore about the antiviral drugs that is given and why this antiviral drugs is given to control the viral infection, because the virus is basically still in the hepatocyte. Yeah, so you need to explore the routes that is given, so you can actually go further in to see what are the antiviral drugs that is given. Okay, any ideas what antiviral drugs are given? Anyone? No. Okay, they are given interferons. Interferon is usually commonly, if you talk about Donald Trump, he's given interferon when he has COVID.
Yes, doctor.
Yeah, so he's given interferon, so basically to block the RNAs from synthesizing, or even actually the viral penetration, protein synthesis, or even the methylation of the mRNAs, or translation of the viral protein assembly. So you can read about interferons, and then this case you can also give the patient with ribavirin, yeah, or even sulfobusviral. So you can actually read out the antiviral drug that is used for hepatitis C. Yeah? I leave that for you to explore and the mode of action. Is that okay?
Doctor, I have a question about the hypokalemia just now. So basically, the hypokalemia will inhibit the sodium-potassium pump in myocardial cell, is it?
No, hypokalemia, that means there's low potassium. Low potassium in the ECF, which means that you either excrete too much potassium. Okay.
And how?
Sorry.
I mean, how it becomes the tachycardia is supposed to be hyperdepolarization, right?
No, when you have a lot of potassium that is actually leaking out, coming out from the cell, okay? When the potassium come out from the cell, basically you are going to hyperpolarize the cell, And generally, usually the hydrogen ions will actually get into the cell. So you actually cause also alkalosis in the patient. Okay, but this low potassium can actually slow down the heart rate. Sorry, this Hanani, that's what you mean. Why does it cause tachycardia? Right? You say it's supposed to be actually slow down the heart rate because of hyperpolarization of the myocardial site. Is that what you mean?
Yes, doctor.
Yeah. So if there is hyperkalemia, then it can actually cause hyperpolarization. Okay. Then it can actually lead to a slowing down of the heart rate, not tachycardia, as I mentioned just now. Or if you does not excrete so much because you use the diuretic that is called what we call this potassium sparing, then you can sometimes lead to increase in potassium called hyperkalemia because you are not excreting the potassium. Okay, so that's why they use in combination of both loop diuretic or thiazide or even the loop diuretic to combine with the potassium sparing diuretic so that you can have the balance. Is that okay, Hanani?
Okay, doctor. So basically, hypokalemia causes bradycardia, and it also will cause the weakness of the muscle in the body,
Yes.
right?
Yes.
Okay, thank you, doctor.
Yeah. It can also cause alkalosis. Yeah. Metabolic alkalosis. Okay. Okay, so we have done.
Doctor, the metabolic alkalosis because of the composition from
Because
the
if
hydrogen, right?
yeah, if let's say you are not excreting let's say you are using low diuretic, you actually lose a lot of potassium, then it causes hypokalemia. Then the hydrogen ion will actually get into the cell by replacing the potassium that leak out from the cell. So it can actually increase the pH, causing alkalosis.
Understood, doctor. Thank you.
Okay. Thank you. You will learn that a lot when you do later urinary system. So you have to know about this metabolic alkalosis and how potassium and hydrogen ions involved in the exchange between in the cell. Yeah. Okay, so we are done with the management of the patient. So I leave you to explore on antiviral drugs that is used in hepatitis C. Yeah. Is that okay?
Okay, doctor.
Okay. So any other learning issue that we have not covered yet? This is the last one?
Yes, doctor.
Okay.
No, we have the last one by Sarah.
Okay, my Sarah. Yeah, psychosocial issue. Sarah, are you there?
Yes, doctor.
Okay.
So psychosocial issue. Can you scroll down, please, Daniel? Okay, so the patient was diagnosed with liver cirrhosis secondary to chronic hepatitis C, and so these are some of the psychosocial issues experienced by Hep C patients. The identification of neuropsychiatric and neurocognitive symptoms is important during and before the treatment, and I'll get to that. I get to ask to why we should do that later. These symptoms, which include depression and cognitive disorders, are eventually associated with Hep C neurotoxicity. So the negatively, this will negatively. Sorry, I can't read. It's really, it's not zoomed in. One second.
Basically, what you say is this can affect the quality of life, right? So the people with liver cirrhosis, they also have other toxicity problem, said Sarah?
Yes, basically just about a little more about the hepatitis C virus brain syndrome that I found, and it's basically that the patients with Hep C will probably have this syndrome. It is generated by peripheral immune response affecting the CNS. And there's neural inflammation associated with the CNS in Hep C in general. And so what happens is that showed evidence that Hep C virus can cross the blood-brain barrier, and then it will replicate in the CNS, emerging through infected monocytes and infecting microglial cells. Using some technology in patients, they found that an increase in basal ganglia and white matter choline and creatine ratio in patients, suggesting an altered metabolism in patients with chronic Hep C. These results were not explained by hepatic encephalopathy or history of drug use. So, like, they can happen in any Hep C patient. They don't have to be previous drug users. And yeah, and so how are these symptoms manifested? Neurocognitive impairment is, one of the major symptoms, and it's actually also one of the most common extrahepatic manifestations of Hep C. It can lead to subtle changes in processing speed, memory, attention, fatigue, and cognitive performance. And up to 50% of Hep C infected patients may develop clinical or subclinical manifestation of this dysfunction. And
okay, so you need to basically give a lot of support to the patient. But I think you need to give antiviral treatment because that it will help to actually clear out the virus in the body. There's one way. And the other thing is there's a lot of this psychological support to basically allow the patient to get through the disease. That's right, Sarah?
Yeah, that's mainly it. Should I read the last point, the conclusion?
Yes, please.
Okay, well, the first one is the clinical importance is basically the neurocognitive profile of these patients before treatment needs to be addressed due to the possible implication on the treatment course. Example, non-adherence like behavior due to cognitive abnormality. And that's why we should test their cognitive before we start treatment. And then patients with Hep C often feel stigmatized and unsupported in their care, relationship, work environments, while simultaneously coping with physical and psychosocial symptoms. This synthesis points to areas where greater education, compassion, patient-centered healthcare, etc., can improve with dealing with Hep C. Thank you. I'm sorry, I was being attacked by the cat.
Okay. It's okay. Yeah.
Doctor?
Yes.
Farah actually has not presented yet.
Yes, doctor, about the principle of treatment.
No, I think basically the psychosocial issue, the main important thing is basically the medical support that is required. You need to basically give a lot of support to the patient. So that is more important. Yeah, so on the psychosocial issue. And also basically most of these patients also have other probably the virus also get into the brain that can actually cause the psychological change in the behavior. So that need to actually evaluate it before you commence in the treatment. Is that okay?
Yes, doctor.
Okay, so I think that should be the last part. If you have any other question, if not, we should end the PBL today. I hope you learn a lot from here.
Doctor, I just want to ask.
Yes.
About the diuretic just now, it is mainly for the ascites, right? Not for the hypertension?
Yes, it's for the ascites.
All right.
The hypertension is only the portal hypertension because that one you can't do anything unless you do liver transplant.
Oh, okay, doctor. Thank you.
Okay, thank you. So
because in the podcast 4, it mentioned the diuretic because of the portal hypertension.
Yeah, it says about portal hypertension, but mainly is actually to remove the ascites, and from there you can actually reduce the pressure in the portal vein because all this fluid will be removed through the kidney.
I understood that.
Okay. Okay, so I think you have learned and we have discussed quite a lot. Some of you actually read some of the learning issues that you have, but I think it's a good discussion. Okay, so yeah. Okay, we should end now. I think it's almost 2 hours now. We have finished our PBL. Okay.
Okay, doctor. Thank you.
Okay, thank you. Okay,
Thank you.
bye-bye.
Thank you also, doctor.
Thank you. Okay, bye-bye.
Thank you, doctor.
Okay, thank you. So I will leave now.
Okay, doctor.
Okay, thank you.
Yes,
Bye.
okay.
Okay.
Okay,